So good afternoon. Thank you so much. It is a pleasure to be with you today. This is the House and Health and Government Operations Committee, the Public Health and Minority Health Disparities Subcommittee. And this committee is the one responsible for a lot of the public health work. Thank you so much. And I want, Edie, can you mute yourself for a second? House and Health and Government Operations Committee. Thank you. The Public Health and Minority Health Disparities Subcommittee. And this committee is the one responsible for a lot of the public health work. Thank you. And I want, Edie, can you?
I'm doing that now.
Mute yourself for a second?
Yes.
Thank you.
Yes.
Yep. Public Health and Minority Health Disparities Subcommittee. And this committee is the one responsible for a lot of the public health work. And I want. Thank you very much. So we need to just all be flexible, right? It happens, and I'm grateful, Edie, for your work. So this is the committee responsible for all the public health bills. This committee is the one that listens to the bills and works on it. So I'm very grateful to the committee members because you're doing a lot of work, especially during this pandemic. A lot of the bills that we have passed are bills that are helping our constituents. So I thank you for coming today to the meetings and the meetings that are going to come, and for our guests. Thank you so much for being here. I want to thank Erin Hopwood, who's actually the staffer, lawyer, amazing. She's the amazing person that staffs this committee. So I want to thank her. Also, I want to start, there's two actually panels today, the 988 Opportunity to Improve Maryland Behavioral Health Care. And we're going to have two speakers on that panel. In the second panel, the update from the HSCRC's Behavioral Health Work Group. So we're going to start with the first panel, the 988 Opportunity to Improve Maryland Behavioral Health Care. We're going to have our first speaker, Adrienne Bridenstine, who's the Vice President of Policy and Communications for Behavioral Health System Baltimore. And we're going to have the Director of Policy for the Behavioral Health System Baltimore. Welcome. Can you get started, please?
Great. Thank you, Madam Chair. And if you'll give me a moment, I'll share my screen.
Sure. Thank you.
There we go. I think we're live. Good afternoon, Madam Chair and members of the committee. I'm Adrienne Bridenstine, Director or Vice President of Policy and Communications at Behavioral Health System Baltimore. And thank you for the opportunity to speak with you about the 988 opportunity that's available to us in our state. For those who aren't familiar with us and who we are at Behavioral Health System Baltimore, we are a nonprofit that serves as the local behavioral health authority for Baltimore City. So in that role, we oversee the full range of mental health and substance use services for Baltimore City, including behavioral health crisis services and among other services that are not fully reimbursable through that fee-for-service system. A big part of what we do as system managers is supporting our provider system as it transitions through change and supporting access to behavioral health services. And that is where 988 comes in as a really critical opportunity for not only Baltimore City, but for our entire state. BHSB has a role and a stake in supporting our provider community with this incredible opportunity as we do transition to 988, not only with supporting our crisis providers and that continuum as we transition to supporting this new number, but also with promoting it within the community so that we can promote better access to not only behavioral health crisis services, but that broader continuum of care of services within our community. For those who aren't familiar with 988, very quickly, it is the new three-digit hotline number that is replacing the current 1-800 number that already exists for the National Suicide Prevention Lifeline. So that's a number that's been around for a long time. You'll hear a lot more about that from Dan in a little bit. But I wanted to set some context for you all and explain how this fits in within our crisis response. Within the state of Maryland, we know that we need crisis services for anyone, anywhere, and at any time. And we have components of our crisis system in Maryland that are really good. The 988 or the crisis call centers are that one component of the crisis system that's someone to call. They need to be around 24/7, and they're really the backbone of any continuum of crisis response services. It can be the first place that somebody calls if they're looking for help. It can be the number that somebody calls if they're looking for resources or referrals within their community. It's also the number that people can call if they just need a counselor or someone to talk to. So that's why we look at it as one of the backbones and key parts of our crisis response system. Maryland has other components of the crisis response system, like mobile response teams, that's the anyone to respond, and crisis stabilization centers, that's the anywhere to go. But again, a pivotal piece of it, as we see it, is that that 988 and the crisis response system, or sorry, that 988, that crisis call centers. So one of the things that I really want to emphasize with this 988 opportunity is that 988 is a national initiative coming at the direction for SAMHSA, which is the national level entity, part of HHS that oversees behavioral health services at the federal level. It's also coming at a time when there's this growing need for behavioral health services. Some of that is a result of the COVID pandemic. For example, in Baltimore City, our local crisis hotline has seen a doubling of calls for help since the pandemic started almost 2 years ago now, and our call volume has remained that high, and you'll see more data about that in a little bit later. But it's also coming at a time where there's growing recognition for the value of crisis services and that they can serve as an alternative to having law enforcement come out or having people end up in our emergency departments for care, which is sometimes not the best response or the best place for people to show up for care when they're experiencing a crisis. So there's a lot of opportunity with the timing as it relates to how 988 and when 988 is being implemented. With the transition to this new number, we believe that Maryland has the opportunity to build upon the strengths of our current crisis call center network, of which we've had call centers across the state of Maryland in existence for a long time, although they've not, in our view, they've been under-resourced for a long time. But the opportunity that we have available to us as a state is to build upon that existing network, knowing that with a number that's complementary to 911, like 988 is, that we could see an increase in call volume to our existing call centers, which means hopefully an increase in people getting access to the care that they really need, whether it's crisis care or, again, that connection to that broader system of care. So there's a lot of opportunity for us available. It's also, with this being a national initiative, it gives Maryland the opportunity to help lead the country with implementation and transition to this new number. So for a little bit more context, I'm going to turn it over to Dan Rabid to explain to you more about how the current Lifeline already works and some of the timeline that's in front of us.
Thanks, Adrienne. And hello, delegates. Thanks so much for having me. My name is Dan Rabid. I'm a Director of Policy at Behavioral Health System Baltimore. So like Adrienne said, I think one of the key things to take away from this is that this is not a brand new system that 988 is developing. The National Suicide Prevention Lifeline has been around for over 20 years. And 988 and the implementation of 988 is a new 3-digit number. It's also an opportunity for states and the federal government to pause and assess whether the crisis system that we have in place today to serve people who are having thoughts of suicide or are overwhelmed by other mental health symptoms or need someone to talk to due to serious trauma or distress, whether that system is what we want it to be and is the ideal system. And while Maryland has a lot of great services, I think Maryland, like pretty much every other state in the country, is making that assessment and realizing that as we launch this new number, we should also build up the capacity and invest in the system that this number is the backbone for. So it's not a new system, and it's also not a national system. The Lifeline system is made up of local call centers. There's over 180 of them around the state. And so the system that routes the calls is one national system. It routes the calls that are made to your local call center. And just exactly how dramatic of a change this is really up to each individual state. We think this is a great opportunity. We hope Maryland takes advantage of it. but it's really going to take action at the state level in order to realize the full opportunity that this new number represents. Next slide, please. So in Maryland, there are 8 Lifeline call centers today. We don't expect there to be an increase in the number of organizations accredited as Lifelines when 988 launches. The 8 that we have is sufficient, and they have a pretty good answer rate. The way that it works is when you call the Lifeline, if nobody picks up, like if there isn't a staff person that's available to pick up within a certain amount of time, it will go to a backup system that may not be within the state. And we have between 80 and 85% in-state answer rate, which is better than a lot of states. We also have 3 centers that have text chat capability, which is really critical, especially for young people who prefer text and chat to making a traditional phone call. And then each center is connected to various different crisis response services. 988 and the Lifeline is different than 911 in that it's not simply a dispatch system. About 80% of the calls are resolved with just supportive counseling on the phone. You know, just having someone to talk to, having that person be able to de-escalate your situation, provide validation and emotional support. That can be enough a lot of times, but sometimes it's not enough, and sometimes you need to dispatch somebody. And the crisis services that are available in any community is pretty variable across the state. And the connection that the call centers have to dispatch those directly is pretty variable. And then in Maryland, we also have the 211 Press 1 system, which is a parallel system that the state of Maryland was kind of ahead of the curve in developing. And that is a similar system in that you call 211. If you're having a mental health episode, you press 1, then it connects you to your local 211 call center. Many of the Lifeline centers are also 211 centers. So it's really just a matter of like how you get to the same local call center a lot of the time. Next slide, please. The way 988 came about, there was a report done by the Federal Communications Commission that recommended a simpler number for the suicide prevention Lifeline, which is where 988 came from instead of the 1-800 number that exists today. Congress followed up with the passing legislation formally designating 988 as the National Suicide Hotline and kind of framing out the parameters. But Congress left it to states to generate and identify the majority of funding for these call centers. There is going to be more federal dollars coming down than there traditionally has been for this system, but the presumption is that states would provide a significant portion of the funding needed for this new system or for this expansion of the existing system. And that's what SAMHSA did a report on needed resources, and they found the same thing. And Maryland has been convening people to discuss how best to implement 988. The Behavioral Health Administration convened a planning coalition over the course of 2021, and they have been working on a formal implementation recommendation report, which I believe will be submitted to the federal government soon. I know that there was a draft floating around, in recent months, and so we're looking forward to seeing that. The planning coalition also recognized that additional funding will be needed to realize 988's potential, and that education will be needed to make sure that this has the biggest impact as well. And then in July of 2022 is when 988 becomes the number, and all telecommunications carriers will need to be able to route calls to 988 and texts to 988 to the appropriate local call center. Next slide. Maryland, in order to take advantage of this opportunity, needs to increase our capacity for crisis response, both call centers and the related services like community mobile response teams and stabilization centers where people can go to recover from a behavioral health crisis, but not have to go through an emergency room or hospital inpatient process. Some of the things we expect is an increase in call volume due to a more easily remembered number and a federal and national public awareness and marketing campaign. There's a hope to increase in-state answer rates to 90%. We want all the local call centers to have text and chat capabilities so that people who are texting and chatting can be working with their most local call center instead of one in another part of the state. And we want each call center to be able to provide consistent and dependable dispatch of services if the person who calls needs a higher level of care and can't have their needs met just on the phone. So all of those things will need an increase in investment in capacity. And so we wanted to come here to this committee to share a little bit background and make sure this is on your radar. Like Adrian said earlier, this is for the Baltimore City Crisis Hotline, called the Here to Help Hotline, operated by Baltimore Crisis Response Incorporated, VBCI. This is what we saw when the pandemic hit. You can see that it's more than double today what it was in February of 2020. We don't expect that to change. This is before any of the marketing or promotional activities that we expect with 988 are implemented. So we're happy to answer any questions that you may have, and really appreciate the opportunity to brief you all on this important initiative.
Thank you. This is exciting to be able to have all the localized resources, right, in one place. It's especially during these last 2.5 years, where the number of suicides have gone up, behavioral health. It's a big issue. So thank you for your work. Are there any questions from our members? Let me see, 1 second. If you could be so kind and raise your hand. I see Delegate Bagnall.
Thank you, Madam Chair. And thank you for this presentation, this effort. It is very exciting. And you answered one of my questions in your presentation, which was about the national effort to transition the education, the media piece. But digging down locally, that answer rate, do we know? Do we have numbers to extrapolate the answer rate of the calls coming into the crisis centers versus the Veterans Crisis Line versus the Spanish subnetwork? Are the answer rates similar, or do we have that data?
That is data that the State Behavioral Health Administration does collect. I do not know if it is broken out by those different subcategories that you just identified. But I can say through the planning process that BHA has led up is that is one of the data points that they are looking at as they're planning for transition to 988, knowing that whatever the baseline is, they may need to go up to get to 90% or make adjustments elsewhere. And just the point of making adjustments, that's one thing for sure. All of the entire state is going to have to be adapting as we transition to this number. We really aren't sure what the call volume is going to be. And without knowing that, and then knowing what you want your answer rate to be, we're going to have to be making adjustments as we move forward with this. So that's definitely something that we, as the local behavioral health authority, will certainly be paying attention to in collaboration with the state.
Thank you so much.
Thank you, Delegate. Any other questions? I'm looking at the participant to see if there are any hands that are raised, and I do not see any. So I just want to thank you so much for being with us today and for the update, and please keep us posted, okay? Let us know if you need any help. Next, we have our pleasure, the second and last panel of the day. It's the update from the HSCRC's Behavioral Health Work Group. Just to give a short summary, we passed House Bill 1121, which creates a bed registry in Maryland. And they have we asked the HSCRC to put together a small group to see what can be done in the meanwhile, while that system is being built, because it's going to take years, right? And we have constituents that are in the ER waiting for hours and days and weeks to get a bed and find resources. So they're here today to give us the result of that. subcommittee discussion. So we have Megan Renfrew, the Associate Director of External Affairs with the Health Services Cost Review Commission. And then we have Dr. Aliyah Jones, the Deputy Secretary for Behavioral Health for MDHA, and she's available for questions. And the last person, Marshall Henson, who's also available for questions, who's the Director of Operations for Behavioral Health. So welcome, and thank you so much for doing this work that the committee requested. We're very grateful. Will you please get started?
Absolutely. So I want to thank the chair and the subcommittee members for inviting us to present today. I also want to note that Katie Wunderlich, the executive director of the HSCRC, is also here to answer questions. And I want to thank my Hannah Friedman Bell, who's my staff person who's driving the slides today to make my life a little bit easier. So I appreciate that help. So just to get started, why are we here? Hannah, could I have the next slide? Edie wait times in Maryland.
Hold on 1 second. If I may ask, if you're not muted and you're not the speaker, would you be so kind and mute yourself? We really appreciate it. Thank you, Megan. Go ahead.
You're welcome. So ED wait times in Maryland have been higher for the nation for a long time. That's been a problem that HSCRC and other state agencies have been aware of and have studied. And that problem is worse for behavioral health patients. And the impact of that problem is even worse on patients with complex needs and those who are under the age of 18, so children and adolescents. And one thing that I will touch on more than once today is that no single intervention will solve the problem of ED wait times. The problem is complex and the solutions need to be multifaceted. Today, I'm going to give an overview of the content of the report that HSCRC submitted last week. And that will include an update on the registry. And then I'm going to talk about some challenges that we see remaining that were raised by members of the work group. And then obviously I will open it up for questions. So next slide. So in September, HDO held a briefing on House Bill 1121, the Registry and Referral System bill. And in that briefing, we heard a number of questions. What are the short-term solutions that could be implemented to address the lack of psychiatric beds, crisis support, reimbursement and payment for psychiatric services, and weak reinvestment of federal government and revenue for reform dollars? And what solutions can be implemented to address long ED wait times for pediatric patients, including children with developmental disabilities? So those are the questions I brought to the work group. Next slide. We created a work group that had membership from a number of state agencies, including MDH, the Opioid Operations Command Center, the Maryland Healthcare Commission, as well as a number of non-state entities, including MHA, CRISP, behavioral health advocates, and legislators. And we held 2 work group meetings in the fall. The first was used to gather input from the work group, just sort of generally in response to those questions. In between the first and the second work group, I and my staff worked closely with the other state agencies to write a draft report, which was then reviewed in the second work group meeting. Next slide. So in the report, we focused on 3 things, 3 sort of large categories that could help with ED wait times and also the problem of hospital overstays, people who are in hospitals with behavioral health diagnoses who are ready for discharge, but they don't have a place to go. And those 3 areas are helping people stay stable. So this is what can we do in the community to help people get care when they are sick, but not in need of crisis level services, or maybe are stable and just need the support they need to stay stable. And those are, the more we can support people when they're at that stage, the fewer crisis services and ED visits we need. We also talked about how we help people who are in crisis. The state is working hard, both in the state government and organizations like Adrian's, to strengthen community-based behavioral health crisis response systems, to provide care for people in crisis in the most appropriate setting. And often that setting is not an emergency department. It's a crisis center, or it's a mobile crisis response team coming to the person where they are, or a number of other different crisis supports, which I'll talk about in this presentation. And then finally, we do know, even if we have our community health system as strong as it can be, that there will be people who need to go to the emergency department and who need hospitalizations. And so how do we ensure that we have adequate capacity, reimbursement, and technology to connect patients in the ED and hospital beds with the appropriate care, whether that care is in the hospital or in a community-based setting? So for example, someone may show up in the ED in crisis, but what they need is not an inpatient bed. It may be an inpatient bed, but it could also be a residential bed that is not in a hospital. And so just how do we make sure the hospitals have what they need to make those connections to the appropriate care setting? Next slide. So in the area of helping people stay stable, there is some ongoing work that I wanted to highlight that either started within the past couple of years or is starting soon, that I think is going to make a difference for people in Maryland. There are more programs described in the report than what I'm going to cover today. And so I do encourage you, if you are interested in this topic, that you do take a look at the report. But the 3 programs related to people staying stable in the community that I wanted to highlight are first, the Maryland Primary Care Program. We talked about this with you when we talked about when we had the total cost of care briefing last week. All Maryland primary care program practices are required to integrate behavioral health in their practices in some way. That's a tremendous progress forward on behavioral health for folks in the Medicare program. The Collaborative Care Model pilot program does a similar thing for Medicaid. So it is integrating behavioral health into primary care. And I think that bringing behavioral health services and connections to where people get their primary care is really a hopeful step towards helping people stay stable and get the services they need. Another program I want to highlight is the maternal opioid misuse model. This is a Medicaid program to support moms, pregnant women, pregnant people, and postpartum people who have an opioid misuse disorder, so that they're getting all the services they need to help both they help them be as healthy as they can be and also help their children. Next slide. So then in the category of helping people in crisis, as I said, the state is doing a lot to try to build out a crisis services support system in the state. This map is from BHA and shows where there are crisis services throughout the state, including crisis centers, crisis bed providers, crisis intervention teams, and mobile crisis services, as well as other types of care. Next slide. And again, this is an area where substantial work is being done to continue to make forward progress. As you know, HSCRC put $79 million on the table for crisis services through a 5-year grant program that started last year. This will help build crisis supports that are based on an evidence-based crisis model called Crisis Now. And then Medicaid recently received a planning grant from CMS. They got that in September, which will help them plan how to use the Medicaid program to fund crisis services, which would be a huge step forward in sustainable funding for crisis services. And then finally, MDH's master facilities plan included adding 24-hour regional crisis centers geographically diverse across the state to further build out the crisis services system. And I just want to note each of these programs is really going to help people have a choice other than the ED when they are in crisis to get services from folks who specialize in behavioral health in locations that are designed for providing care to people who are having a behavioral health crisis, and to have an experience that's very different than the experience they get in an emergency department. Next slide. So then we do know that people will end up in the emergency department, and there are some programs here I wanted to highlight. At the very end of 2021, MDH started an adolescent hospital overstay grant program. I think this is tremendously exciting, especially as they expand it over time. This grant program provides funding to RTCs, residential treatment centers. RTCs serve adolescents and primarily adolescents who need residential care outside of a hospital. This grant program is particularly focused on providing beds for people, for adolescents who are the highest need, that have previously had a hard time finding an RTC bed. And so why is this program important? It's important because there are some folks coming into an ED who don't need an inpatient bed, they need an RTC bed. And if they can't find an RTC bed, they get stuck in the ED. And similarly, there are people who have had an inpatient hospital stay who are ready to step down. And if there's not an RTC to take them, then they get stuck in the hospital bed, and then that hospital bed is not open for the person who's waiting in the ED for that bed. So it just backs up the whole system. So I think this program is tremendously important, and hopefully we'll see it making a change in this calendar year. MHCC also made some recent changes to their state health plan, which is their regulatory structure for approving certificate of needs for inpatient hospital psych services, for psychiatric services in the state, largely hospital-based, specifically to look and evaluate whether projects are considering the needs of adolescents and youth and other special populations. And so I think that will help as facilities consider building more psych services. It will help those facilities fully consider whether they are adequately serving the populations that most need this care. I also listed in the report several hospital capital projects that are ongoing that will add adolescent and child beds in the state, which I think will be very helpful. And then the Maryland Readmission Reduction Program, which starts this year, will target people who have serious mental illness and who are high utilizers of emergency departments, and give them a team of case managers to provide 24/7 care coordination and support over a 30 to 60 day period, and help connect them to the services that they need to help them stay out of the ED. So this is to help people who probably experience ED waits pretty frequently, and who also, by keeping them out of the ED, there's more capacity in the ED to serve other people. While at the same time they get the services they need to be healthier. And then finally, at the end of the year, and this is very exciting news, Medicaid got approved by CMS for a waiver to the Institutes of Mental Disease exclusion in the federal Medicaid program, which would normally prevent Medicaid from paying for care provided to patients in psych hospitals and residential behavioral health care facilities that have more than 16 beds. So getting that waiver means that we can reimburse providers as a state for Medicaid beneficiaries who are in those facilities that are larger. And that's just a tremendous, it opens up a source of funding that's sustainable and really important. So I think each of these programs can make a difference. And again, as I want to to say, as I said at the beginning, this problem of ED wait times and inpatient overstays is complex, and each of these programs is going to make a difference, and no one program isn't going to entirely eliminate this problem. So it's going to continue to need creative solutions and incremental progress, but with the goal of making a difference in the lives of patients and also, frankly, hospital staff, which is something we at HSCRC are concerned about at this moment in time. So next slide. So now I want to turn to the registry and referral system. I know that MDH has been providing periodic letters to update you on the status of that system development. So I'm just going to provide a quick update, but my colleagues from BHA are here to answer questions if you have them. So first of all, high-level staff meet weekly on this project. I sit in on those meetings. I see, the constant work they're doing to make progress. The advisory committee has been established and met. The most recent meeting was January 7th. A project manager with specialized experience in government IT projects started work at the very beginning of January, which while a lot of state staff have been involved in this project, having a dedicated staff person focused on this will be tremendously helpful in continuing to move it forward. And I think, as you know from the hearing in September, a feasibility study was completed. That was done by a contractor on behalf of MDH, and it provided an initial project timeline, identified 3 potential vendors, and described the experience that other states had had with those vendors. That timeline will be built out by the project manager, so there'll be more specific timelines in the future. But that gives a rough idea of what MDH expects the timeline to be. MDH also applied to do it through the Major Information Technology Development Project to include funding for this project in the proposed fiscal year 2023 IT budget. I believe that submission is under review. I don't have an update on that, but it's possible my colleagues will. MDH has also been researching existing registries to determine which would be the best fit for this use case, so that we're not building a registry from scratch, but rather taking advantage of registries that already exist. And then finally, MDH has designed a pilot project, which was required by the statute, and is actively working with jurisdictions to determine the pilot locations. So once funding's secured, which hopefully will occur for fiscal year 2023, a standard procurement process will occur, which will ensure that all the willing vendors are fairly evaluated to find the best solution for the state, while ensuring that the selected technology solution conforms to the requirements of HB 1121. So next slide. So I do want to talk about a few remaining challenges that were identified by the work group. So one is data. Understanding the problem of ED wait times and the related problem of capacity, both in the inpatient setting and in community-based settings. The data that would be most helpful is not currently available. For example, CMS used to have a measure at a national level of ED wait times for behavioral health patients. They no longer maintain that measure. So in thinking about, for example, if we were trying to set a benchmark for measuring progress on this, we can't use that measure anymore because it's no longer being collected. At HSCRC, we are working on recreating that measure at the state level, but that's going to take some time. So we're in a moment of a data gap. And I think others, including MIMS and BHA, are trying to fill that data gap through studies that are at hospitals. But I think there is space for data to be improved on this issue. Sustainable funding is also important. Many behavioral health services are funded in part or fully through grant funding. The other major source of funding for behavioral health services is reimbursement from payers like Medicaid, Medicare, and commercial insurance. Reimbursements from payers is a relatively sustainable funding source. Grant funding is not. It's often short-term. The requirements for grant funding change over time. It may not align with the priorities we have here at the state. And so that's a place where stakeholders are going to continue to work together to try to develop an approach to leveraging the funding we have here at the state into a sustainable solution, and with a particular focus on crisis services. And then another thing I wanted to mention is investment in the community-based behavioral health system, including improving behavioral health care in primary settings, and also providing somatic health care in behavioral health treatment settings. So these are important places where more investment could be helpful to help people stay stable and improve access at the community level. Another thing that came up in the work group was legal issues. This can be a factor in moving a patient to an appropriate setting. This is especially true for patients who are under DHS supervision, though it also impacts patients who are involved in the criminal justice system. MDH works closely with other agencies to collaborate to resolve this issue, but that problem can increase wait times and hospital overstays. And then finally, the behavioral health workforce. I think you're probably hearing a lot about the healthcare workforce overall, but there is an ongoing workforce shortage in the behavioral health workforce. It's exacerbated by low salaries and high educational requirements for some of the roles that are required in the behavioral health space. The work group raised some suggestions, including increasing funding for incentives for providers to help pay for educational loans, making sure that university curriculums are ensuring that patients are getting the most up-to-date and accurate information for best practices to prepare them to serve patients, including information about medication-assisted treatment, and then reducing barriers to entering the workforce, including fees and tests for certification, and looking at scope of practice regulations that may prevent lower level staff from providing care. So I think those challenges are things that I think stakeholders can continue to work together on, state staff can continue to work together on, but I did want to bring them to your attention. That is the end of my presentation. I'm happy to take questions. I did put an appendix into this deck that includes links to other reports on this topic if you're interested in diving deep. So I'm going to pause and ask if there are questions.
Thank you so much for your presentation and for taking the time to do this work. At this time, I'm going to ask committee members if there are any questions. I'm going to start with Delegate Terry Hill. Delegate Hill.
Thank you, Madam Chair.
Thank you.
Let me, since I'm not sure, I don't want to take up a lot of time, I'm going to just list the questions and then you can address the ones you're able to so that I won't block time for other people, if that's okay.
Yep,
that's fine.
And thank you, first of all, for all the work you guys have been doing in response to a real need and the legislative directive. The first question is you talked about how you're trying to deal with the hospitals, the ER, the crisis intervention, all that. What I was missing, and maybe I just missed it, the number of people we're talking about. When we talk statewide or by region, can you get us, what are the numbers of people we're talking about that are requiring this service? And, what are the numbers of people who are on a weekly basis stuck in the ERs taking more than 24 hours to find bed availability? Because that would help me have some context. So that's the first one. The second is you talked about, you showed us a map of the CIT locations and you talked about the plans for 24/7 regional crisis centers. I'm trying to get clear about what the capacity of those regional crisis centers are. Do they have overlap capacity or they're literally just outpatient for however many hours, up to 23-hour stay? And what's the onboarding timeframe we're looking at? The third is I would like an answer to when we talk about the youth. I've lost what happened to the students who were treated at the Good Shepherd School when it closed about 4 or 5 years ago. And I'm just trying to get a sense of where our students or our youth are now, and if these new plans are going to adequately address their needs. And then finally, when you talk about how much work you've done with the registry, I'm interested in knowing how you all have decided, if at all, to adjust your RFP, because we had so many problems with the last group that was contracted with. So I want to know if you're asking different questions, weighing things differently going forward, so we don't end up with the same or a reasonably similar problem with having a contract with a vendor that is really not able to do the job. So those are the questions. Thank you. Thank you,
Okay.
Madam.
So I would like to turn these questions to my colleagues at so Marshall or Dr. Jones, if you'd be willing to take these questions.
And may I ask you, while you do that, can you please stop the sharing so that we
yes.
can go back? Thank you so much. Go ahead. You can answer the questions.
Thank you. Thank you for giving us the opportunity to be here. And thank you, Delegate. Thank you for those very, very good questions. So with regards to the number of people that we're talking about that are sitting in the emergency departments for more than 24 hours, that's a question that we would need to do a little bit more research to find the answer to that. So that's a question we're going to have to go back and get the answer for. There's lots of reasons why people are in the emergency room, not necessarily because they're are waiting for a bed. You know, if someone's there because they need to sober up, they could certainly be there for more than 24 hours. So the question that you're really speaking to is who's waiting for a bed for more than 24 hours. And that's not, as far as I'm aware, that's not, that pinpoint information is not information that we have at our fingertips, but we can see what we can do to get it. We would have to, we'd have to work with the hospitals to try to get that information.
And when you do that, could you give us that whole context also? The people who are just waiting because they have to sober up and release, they're waiting for outpatient treatment, whatever that context is, so that we know when we're talking about numbers, we have some denominator.
Certainly. Right. Certainly. We can give the whole picture. Yes, I understand. The second question with regards to the regional crisis center's capacity and services provided. So we are still trying to make determinations about that. With regards to capacity, the idea obviously with the regional crisis centers that are through MDH is not that they are going to be the only crisis centers that are going to be in specific areas or regions. These are just going to be crisis centers that are supported by the state from an operational expense perspective. The idea wouldn't be, because otherwise, part of crisis services is making sure that they are localized enough so that they can be effective. And so we, and we're only at this point in time looking at dividing the state into 6 regions, and we're starting with talking about 6 regional crisis centers. And so that's obviously not going to accommodate everybody in the state who needs a crisis, who's in a crisis. However, we certainly will be making assumptions about how many people would be served by each respective center as we kind of pinpoint exactly where those centers are going to be. So that's information that I'm sure we could give you estimations about where when we do the first center, which at this point in time we believe is going to be in Western Maryland, what the assumptions are going to be for that location, and so we can certainly give you that piece of information as we develop it. But we're not so far that we know exactly what the communities are going to be served, and therefore what the need exactly is for the number. With regards to the number of persons, the types of services that are going to be rendered, we're making determinations about that as well. The expectation is that what we're talking about from an MDH perspective is that these are comprehensive crisis service centers. And so they would involve services for outpatient, transferring people to inpatient if they need to be inpatient, some measure of crisis stabilization, and perhaps even some short-term crisis beds. We haven't finished building out that idea just yet, but the idea is that they would be comprehensive services, and comprehensive crisis meaning provide, provide a set of standard for what crisis service centers are supposed to look like throughout the state.
Okay, Dr. Jones, may I presume also then that some of that information will depend on you will have done an assessment of what the private crisis support systems are in the area and what the needs is, so that we're going to try and fill in for what's not already there. So it might be different in Western Maryland than Southern Maryland.
That is correct. We are trying to determine. So, and that kind of gets to the other work that we're doing through our crisis services like advisory work group, and also through a grant that we have through CMS to look at the crisis system, well, to really help accelerate the work that BHA had started with regards to looking at what the landscape of services is for crisis services in the state of Maryland, and helping us to build out and put flesh to the bones about what exactly does a good and robust comprehensive crisis services system look like for the entire state. So we have, I think we got about $800,000 from CMS to engage a consultant to help us with this work, so that in about a year's time, we would know exactly what it is that we are trying to do in terms of what the landscape is, what the needs are, and how also to fund, and thoughts about how to provide funding for those programs as well. So that I think that okay, good. And then with regards to Good Shepherd and where those children are now, that's a question that we'll have to bring back to you. The answer to that I'll have to talk to my team and find out exactly where those children were placed. I know that all of the children got support and assistance to move to another program that continued to be in existence.
And it's not just the ones who were there then, but with that being closed, the students who would have been sent there now, but it no longer exists, what takes its place? That's really the question.
So, and that gets to the questions around capacity for residential crisis, which is certainly something that we've been looking at very, very closely through the work for the hospital overstays program, and then also through just the general work that we've been doing around trying to manage what's going on in the emergency departments, or the work that we want to do with managing what's going on in the emergency departments across the state. As it stands, right, there are numerous challenges. There are numerous challenges with regards to our residential services for this particular population. However, we do know that there is a capacity, I think at this moment, and Marshall, you're gonna have to help me out on this one. There is a capacity for children who need residential services at this point in time. We don't have 100% capacity at our residential at our residential services for children who need RTC services. Marshall, do you wanna add a little bit more to that?
Yeah, I think that's right. So, we see at any given time right now capacity for service for about 30 to 60 individuals. Now, I will qualify that and say that the COVID surge, the COVID pandemic, et cetera, has created a number of staffing challenges for the providers that serve in the RTC space, in the residential treatment capacity space. And so, although those beds may be in existence at any given time, they may not be fully staffed at any given time. So we're constantly tracking those, constantly trying to help providers build that capacity, and in some cases reinstate that capacity, right? We've been under this pandemic now for 2 years, and providers have dealt with ongoing staffing challenges.
Thank you. Okay.
Thank you so much for your questions, Delegate.
And Registry RFP, right? That was the last
And
one.
with regards to the RFP, so the whole process that we're using to develop the RFP for the bed registry system is completely different than the process that was used to develop the RFP for the ASO. I think that's what you're referring to. And even the ASO process that we're going through is completely different than it was this time than it was when the initial RFP was developed. We are working in lockstep with our IT partners. We meet with them very, very regularly. And actually our project manager sits within the IT department. And so we are going to ensure that the vendor that it is that we ultimately select is able to meet the needs of We're all obviously laser focused on a solution that's actually a workable solution. And that includes not only the technological piece, but also the operational piece as well. We're really looking at the entire picture.
All right, thank you very much. Thank you, Madam Chair.
Thank you for the questions. And allowing the discussion to flow naturally, because this is such an important issue. And it doesn't matter whether you are all the way in Western Maryland, wherever you are in Prince George's, this is a big issue for all our constituents, and we need to do something about it. So Delegate Heather Bagnall.
Thank you, Madam Chair, and thank you for the work that you're doing. I know that the Behavioral Health Administration has been working diligently on that emergency facilities bill and implementation. I do actually want to segue off of Delegate Hill, though, with my question, because I know we are talking about, the crisis beds and crisis response, but our community behavioral health clinics are such an important part of that coordination of care. And I am wondering where we are in the negotiations for stabilizing those providers as a result of the previous RFP, the vendor issues that we've been experiencing for the last 2 years. Because as we're looking at network adequacy, as we're looking at sustainable funding and reimbursements, we can't have that conversation in a vacuum without recognizing that we've been in negotiations for nearly 2 years for providers who provide services through Medicaid. And we don't want to lose those providers in our coordination of care. And my other question is, as we are looking on how to build this system out, obviously we are looking in two streams because these are crisis cases where we do need stopgap measures, and we don't want to let perfect be the enemy of good. So what do you need from us to move the needle during this legislative session? Thank you.
So who would like to answer that question? And I also like you to consider the money, the budget for the bill. We want to make sure that it's there, especially this year where we have a surplus, that the administration be committed to asking for the money, and that we as a legislative body are also supportive of that, because this bill has to be done, and it has to be done right. So it's best to answer that question respectfully?
So I'll start. So with regards to the ASO and stabilization of the community providers, I'm going to have to take that question back to my Medicaid partners to get a response to that answer, the response to that question. I will certainly say that we are obviously we want to be as supportive as we can of our community providers and ensuring that they are able to collect for the services that they are providing, and the MDH team proper, Medicaid team has said on numerous occasions, I think $30 to $40 million that are paid to our providers on a weekly basis for services rendered. Not to say that the system is perfect. There continues to be some challenges of which I'm quite aware. However, I think that with any other response to that, I'm going to have to take that back to the team and see if there's another response or another addition that they want to add to that. With regards to what the need is, that's a very good question as well. And how you all can be supportive. I think that continuing in a collegial way to provide positive pressure on this issue, which you are doing. And what we're trying to do is to keep you all very well informed and keeping our foot on the gas. I think that the Secretary has is very, very focused on this bed registry and referral issue, and making sure that patients in the emergency departments and across the state have access to the care and treatment services that they need in a timely manner. He's made it very clear that this is one of his key priorities. And so we have been very, very diligently trying to address this issue and have daily conversations about what it is that we can do. Certainly, we have heard from our provider community about their financial challenges. We just had a meeting with the SUD residential providers just last week to hear about the challenges operating during COVID, and they've made a very direct ask for whatever financial support can be made to help them to manage the financial challenges of operating during COVID. And so that certainly has been an ask. Of course, you all know that Medicaid cannot provide grants to providers, nor does the Behavioral Health Administration. None of the grants that we have received from our federal partners will allow us to provide any funding to for operational expenses for our providers. So our hands are a bit tied in terms of what it is that we can do, though we certainly have heard and certainly are happy to advocate on the behalf of the providers about anything that can be done to help support them and continue to support them during this time, similar to the funding that we have gotten some funding for some providers earlier in the pandemic for operational expenses associated with COVID. And that has been helpful and appreciated by the provider community. Megan, is there anything more that you want to add?
I was just going to say that the governor's budget did include a number of behavioral health items, and I think just keeping an eye on, I think the behavioral health crisis is only second to the COVID pandemic as far as pandemics in our state right now, and so just keeping an eye as you're considering the budget on what the appropriate level of funding is, and I don't have a position on that, but I do know the governor included a number of things in their budget.
Okay, and how about the funding to implement this bill? Is it all there?
For the legislation, we're waiting to see if the request for funds has been approved or not. We don't expect to hear about that until I think that within the next several weeks we're expecting to know whether the amount that we requested has been approved or not.
Well, Dr. Jones, will you be so kind and inform this committee if you need any assistance, please?
Most
okay.
Definitely.
And since it's a priority of the secretary, I hope and pray that it does get funded. But if he needs any help from this end, consider us a partner as well. Okay.
Thank you very much.
I don't see any other questions. However, I do want to ask, and if Dr. Jones, if you can get back with me offline, the bill required the hospitals to hire, while the program is being developed, the registry, the bill did require the hospitals to hire individuals to do the calling and assistance and placement into the community. If you can give us an update on that part of the bill, please. If you could do that offline, or if you know the answer now, I appreciate it. But I do recall that being in the bill.
I'm happy to jump in on this. So one of the things that we were looking at is exactly what you're talking about, right? How do we make that connection between hospital EDs and the provider community? There has to be an owner in that process, right? So as we're looking at the immediate impact that we can make, we have proposed a solution where we're going to embed what we're calling a behavioral health hospital liaison within select local behavioral health authorities that will liaise directly with the emergency departments and the provider community to be able to resolve some of those stuck cases on a daily basis. So that's going to be part of our pilot project that we'll be launching very, very soon. And we hope to have some good learning opportunities from there, because we will have someone formally owning that process so that we can further see where the capacity issues are, and within hospitals exactly where people are getting stuck. So I think you can expect to hear more on that as we move forward.
Thank you. And while I appreciate you, all the work you're doing, and it really shows. I really am very grateful, and the committee is grateful, because this is like the #1 issue. Behavioral health is so important as physical health, right? While you are, working on assessing and evaluating various partners and vendors that can customize their platform for everything the bill calls for, I want you to think about are there any off-the-shelf, not the programs that are coming in the future that Megan discussed, that we have all been part of, right? Are there any off-the-shelf vendors that can do 40 or 60% of what the bill calls for, right? Something to help immediately, even while we work towards a comprehensive solution like what you just discussed about having that liaison and everything else that Dr. Jones discussed. If you can think about that, I really appreciate it. And meet with us. We'll meet with you. We'll work with you. You can consider us a partner. I mean it unconditionally. This is really an important issue.
I really appreciate that. We appreciate you guys taking the time and really giving the insight that this deserves. I think I am reminded on a consistent basis from all of the stakeholders that have been involved in the process so far that this is a problem that plagues our nation, right? This is a problem in Maryland, but no state has actually solved this. So if we can get this right, then we can create a roadmap that can help all of those that need help throughout the states. We've got to get it right here first, right? So I appreciate all of your dedication and your willingness to be a strong partner in this effort.
My pleasure. And thank the secretary for me, okay, for making this a priority. Tell him that I appreciate it and we appreciate it. I want to thank everyone for coming. This committee is going to be meeting on Mondays, but the next week we may meet in the morning for a briefing. And then after that, we'll meet at the same time, same day. So just be a little flexible with us. And we'll have some briefings as the bills get filed, right? Then we'll have bills to consider and to vote on. But meanwhile, we're having briefings on issues that are outstanding, like this very important issue, that the work that we have done, right? You pass these bills, you want to stay on top of them. You want to make sure they're implemented. They don't stay on a shelf, that they're actually done because you work so hard to get them through. So I want to thank you again, all the panelists, Dr. Jones, Mr. Henson, Megan, all of you for your time and your efforts. Again, let us know if we can work with you. And to the committee members, Erin and I and my team really thank you for your time this afternoon. We really appreciate you. And we have voting at 4:15, and have a blessed afternoon, everyone. Thank you so much for caring.
Thank you.
Bye-bye.
Thank you.
Bye-bye.